Great, greetings everyone, and welcome to ECG case number 2, or at least week number 2, September 18th. And I am working on the audio and visual. Right now we just have QuickTime, and we're going to try to make this audio visual better over the next few weeks for those people that are interested. Also, you'll notice that the sound quality is not that good. It's because I don't have my microphone with me. I'm actually on a vacation right now with my wife in Florence. Really beautiful city. Here's the view from our rooftop and the nighttime view. It's a really wonderful city, and I'll tell you, I am firmly committed to seeing a University of Maryland conference come to Florence. It's amazing, the art and the food and just everything, Renaissance artwork, and we got a chance to see the famous David sculpture from 1504, and a lot of people don't know that they actually did a reconstruction of the David sculpture and tried to modernize it of how David would look in the year 2011. And this is in a gallery not too far from the original gallery. And this is what they anticipated the sculpture would have looked like if Michelangelo had done David's sculpture in 2011. So certainly if he was living in Baltimore, he'd probably look a little bit more like this. But anyway, it's a great city. Great time, and I honestly hope that we can bring that crashing patient conference or a nice one-day University of Maryland conference to Florence at some point. So anyway, let's go ahead and get started. Some of you, hopefully we'll run through some good teaching points anyway. And so we'll just start out with a quick history. It's a 47-year-old woman with cancer who presented to university feeling weak. She was tachycardic. The rest of vital signs were okay, and the exam was, we'll just say, non-diagnostic. We want to make this simple. I'm not going to go through details of the HPI and everything else. She was under treatment for this cancer also, and I think it was probably breast cancer, as I recall. And so, of course, we got a 12-lead EKG because a woman who's feeling weak, you've got to think about acute coronary syndrome. It's a common atypical, well, it's an atypical but not uncommon complaint for ACS in women, and also people with poor protoplasm, people who have cancer or many underlying other types of medical problems may present feeling weak and not have the typical chest pressure radiating down the arm and so on. So anyways, completely reasonable. You start out with a quick 12-lead EKG in a patient feeling like this, and also you're going to screen for signs of electrolyte problems because she's feeling weak and probably having vomiting and everything else. And here's the 12-lead EKG. And first thing you notice is that she's tachycardic. So let's talk about the rhythm first. She's got a narrow, regular tachycardia. There are some P waves, there are some PVCs in here, but aside from those PVCs, it's regular and it's narrow complex. And we talked about the differential last week. The differential for regular, narrow complex tachycardia, there's only 3 things you've got to think about. You've got atrial flutter with 2-to-1 conduction, and that's what last week's case was about. You've got sinus tachycardia, you've got SVT. How do you tell which of these 3 things is going on? You simply ask, what is the atrium doing? So if you look for the atrial activity, you'll notice that there's a P wave, QRS, P wave, QRS, P wave, QRS. As we learned last week, you've got a heart rate of about 150 plus or minus 20, so you've got to be paranoid about atrial flutter. Flip this 12-lead upside down, look in all 12 leads, look in the rhythm strip, look everywhere, look for flutter, and in this particular case, you don't find it. So this is simply, so there's no tricks here. All right. Next issue is that you'll notice there's diffuse ST segment elevation. When you've got diffuse ST segment elevation, what's your differential? I think a lot of times people skip over this step. They see diffuse ST elevation or maybe even focal ST elevation, and they don't think about the differential. They just jump right to a conclusion. But it's always useful to think about the multiple things that can give you ST segment elevation. Here's a typical differential. I think this differential is actually probably not so good because if you look at the things at the bottom, these are not generally causes of diffuse ST elevation. Left bundle gives you ST elevation, but there's also ST depressions in some places. Same for LVH. Brugada really just gives you ST elevation in V1 and V2. Hyperkalemia can give you lots of ST elevation, but it probably will produce some ST depression and peak T waves and a few other findings. So even though in the textbooks they list this differential for diffuse ST elevation, let's get rid of those things at the bottom. This is the usual quandary that we face when we're trying to figure out what diffuse ST elevation is due to. So let's take these one step at a time. What are the clues that when you're looking at a 12-lead EKG with a lot of ST segments that are elevated, what are the clues that point you in the direction of one versus another? So with a large MI, well, a person with ST elevation in a whole bunch of leads is probably having a really, really big MI. And that patient's going to look pretty darn sick. This patient doesn't. Vital signs are pretty good. I told you that her exam was non-diagnostic. She's not in heart failure. She's not looking toxic. So clinically, she doesn't look like she's having an anterolateral, inferior, posterior MI. And the other thing that you look for with large MIs is even with massive MIs, you oftentimes, not always, but oftentimes will have some leads with reciprocal changes, and you really don't see reciprocal changes in this particular case. Now let me give you the caveat that when we talk about ST depression, we ignore V1 and AVR, okay? So if you see ST depression in any of the other 10 leads, that nails the diagnosis of a STEMI. But there's a whole bunch of things actually that give you ST depression in V1 and AVR, so those leads don't actually help if you see ST depression in V1 and or AVR. What about pericarditis? Well, pericarditis hopefully is going to give you PR depression. We all have learned about that. I got to tell you honestly, however, that PR depression is not always there, so don't rule out pericarditis if you don't see PR depression. But if you do see PR depression in a whole bunch of leads, not just one or two leads, but diffusely, a lot of leads. And I can't tell you how many a lot is, but in a lot of leads. That helps push towards pericarditis. You should never see reciprocal changes except in AVR V1. All right, but if you see reciprocal changes, ST depression, in any of the other 10 leads, you're done. It's got to be a STEMI. The ST elevation should always be concave upwards. What does that mean? Well, take a look at the cursor. The ST elevation should be like this. It should be concave upwards. If you ever see ST elevation that's horizontal like this, or convex upwards like a tombstone, then that's got to be a STEMI. All right, and also ST elevation in 2 is usually greater than 3. If you ever see ST elevation in 3 that is greater than in 2, then that's got to be a STEMI also, pretty much. Okay. What else? Early repolarization. That can be tough sometimes. Often these are relatively young males. If you have an elderly woman and you're calling something early repolarization, you really ought to think twice, think 3 times. It's not impossible, but it's much less likely. Also, no reciprocal changes in any of those 10 leads. V1 and AVR, sure, possible. But none of the other 10 leads should show ST depression. If there is, it's got to be a STEMI. ST elevation, once again, it's always concave upwards with early repol. If it's horizontal or convex, it's got to be a STEMI. And ST elevation is usually greater in 2 than in 3. Once again, if the ST elevation is greater in 3 than in 2, you're looking at a STEMI. And then the last thing, ventricular aneurysm. Well, let's not talk too much about that because honestly, we don't see aneurysms often anymore except on the boards. The one tip-off, however, is if somebody's got a ventricular aneurysm, it's because they had a previous big MI, usually anterior. And those patients pretty much always have Q waves. I've never seen or heard of an aneurysm that doesn't have big Q waves on the 12-lead EKG from their previous MI. All right, so aneurysms don't develop in patients that have previous non-Q wave MIs. It's pretty much always going to be in somebody who now has Q waves. So that can be helpful. And generally, not 100%, but generally you're not going to see reciprocal ST depression in an aneurysm. All right, so those are some clues that can help. So let's take a look at the 12-lead EKG. Actually, before we do that, let's focus for a bit more on MI versus pericarditis. Hopefully some of you are thinking pericarditis with this case. And there are a set of factors that can help rule in a STEMI over pericarditis, some of which I've already alluded to. And here's what I want you to do. If you're ever taking a look at a 12-lead EKG with ST elevation, and you're saying, well, you know, this could be a STEMI, but it could be pericarditis, here's what you do. Step 1, look for reciprocal changes. If there's ST depression, reciprocal ST depression, in any of those 10 leads except AVR V1, remember those, you can have ST depression in AVR and V1 with anything. But if you have ST depression in any of those other 10 leads, stop, you're done. It's got to be a STEMI. All right? Second, if you see horizontal or convex upwards ST elevation, you're done, got to be a STEMI. If you see ST elevation in 3 greater than in 2, you just ruled out pericarditis and early repul, it's got to be a STEMI. And also, if you get serial EKGs and you see evolving changes in the ST segments, or you see brand new Q waves getting bigger and bigger over the course of 20 minutes or 30 minutes or an hour, then that's got to be a STEMI also. Early repul and pericarditis really should not have evolving changes. Okay, so after you've gone through these 4 steps, then and only then are you allowed to look for PR depression. Okay, don't look for PR depression until after you've gone through these first 4 steps. And if you've ruled in STEMI based on any of these 4 steps, then who cares if there's PR depression? All right, because you just ruled in a STEMI. PR depression can actually be present with STEMI as well. And I'm not going to go into the reasons why, but that's why I say don't look for PR depression until after you've gone through these first 4 steps. Then, if you have none of the above, and now you see PR depression in multiple leads, then you can call it pericarditis. Also, if there's a friction rub, which we don't hear often, but if you do hear a friction rub, that's pretty darn specific for pericarditis as well. So let's take a look at that 12 lead now. All right, we'll go through our 4 steps. Is there any ST depression in any of these 12 leads? Again, forget V1, forget AVR. But in any of these other 10 leads, if there's ST depression, it's got to be a STEMI. And you know what? You don't see that. Step number 2. Is there ST elevation, is the ST elevation horizontal or tombstone, convex upwards in any of those leads? The answer is no. It's concave upwards in all of the leads. Even up here it's a little bit straight, but it's just a tad bit more concave upwards. All right, so we go past step 2. Step number 3, is the ST elevation in 3 greater than in 2? If it is, it's a STEMI. Well, in this case, ST elevation in 2 is greater than in 3. So you can't do anything with that. And then step number 4, if I showed you serial EKGs, you would ask, are there serial changes in the ST segments, or are there developing Q waves? And if there are, then you'd rule in a STEMI. And if not, then it doesn't really tell you anything. And in this particular case, if you got serial EKGs, nothing's changing. Okay, so we've gone through the first 4 steps. Now you're allowed to look for PR depression. And when you start looking for PR depression, you actually do see it. You've got PR depression in 2, 3, AVF PR downsloping or PR depression. There's some PR downsloping out here laterally. So you've got PR depression or downsloping in a bunch of leads, and that pushes you towards calling this acute pericarditis. In this patient, we got a quick echo, and there was a moderate size effusion, not tamponade, but a moderate effusion from a met to the pericardium, which does happen with both breast and lung cancer, maybe 1 or 2 other types of cancers also. And this was acute pericarditis. So some of you may have looked at this right up front and said, that's acute pericarditis, and you were right. But hopefully some of the things that we talked about will help in terms of distinguishing the less obvious cases. And you know what? We talked last week about how emergency physicians have to be the experts at electrocardiography, and this is another great case exemplifying that. Let me show you the official interpretation of this 12-lead EKG, confirmed. I'm not going to put the name up there, but this was the official interpretation, acute STEMI. Absolutely incorrect, all right, because they didn't go through those 4 steps. All they said was, there's ST elevations, got to be a STEMI. There's chest pain, got to be a STEMI. And the EKG machine fooled them into thinking it was a STEMI also. You have to be the expert. You can't rely on the machine. You can't rely on the cardiologist either. It's up to you as the emergency physician every single time to be the expert. Otherwise, you're going to give thrombolytics or heparin, clopidogrel, G2B3 inhibitors, whatever, to this patient, and that turns this patient into a hemorrhagic tamponade. All right, don't rely on other people. You need to be the expert. All right, so hopefully that was helpful. That's it for September 18th, and I'll talk to you next week. Thanks a lot.